all audience to the Thursday webinar from CCI. I'm Dr. Keerat K Sibia, consultant pulmonologist from Bhara Super Specialty Hospital from Mohali, Punjab, and I'm delighted to be here with all of you today. Let me begin today's webinar by thanking Dr. N.H. Krishna and Dr. Narayana Pradeep, the founder trustees of CCI. And I want to particularly thank and congratulate Dr. Vijay Kumar Chetty, the webinar director, and Dr. Ravi Dosi, the national secretary for CCI, for coming up with wonderful webinar ideas. When I got to hear about today's webinar, the title, that is Critical Care Radiology, I was particularly very happy with the fact that they have touched on a topic where the pulmonologists who are going in the ICU in and out on a regular basis, this is a step in empowering our pulmonologists in the ICU. Thank you, CCI, for always picking up topics which are very relevant in practice and also in updating the pulmonologists. I would now like to welcome our first panelist for today's webinar, Dr. Nirupam Sharan. Dr. Nirupam is a senior pulmonologist from Ranchi. He is currently working at Happy Rang Center in Ranchi. And Dr. Nirupam is also the CCI state head for Jharkhand. We welcome you, sir. Welcome, Dr. Nirupam. Our second webinar panelist is Dr. Girish Kumar Agrawal. Dr. Girish is a dynamic pulmonologist from Raipur. Dr. Girish is practicing at Ramakrishna Care Hospitals at Raipur. And we are very happy to have Dr. Girish with us today. Welcome, Dr. Girish. Our third panelist for the day is the radiologist for the session, that is Dr. Nikhil Gupta. Dr. Nikhil is consultant pulmonologist at Fortis Hospital, Mohali. And we are delighted to have Dr. Nikhil with us today. Welcome, Dr. Nikhil. Without further ado, let us now start with our first talk for the evening. I'm going to be taking a talk on ultrasound lung in critical care. Ultrasound lung comes handy in the ICU when we want to evaluate a patient for causes of shortness of breath, cyanosis, cough, or shock. It comes particularly handy when the patient is on the ventilator and it is going to take time to shift the patient for maybe say a CT scan, and it is while awaiting a portable chest X-ray to be done. So we want to evaluate for lung pathology, pleural pathology, pericardial pathology, and rule out the possible causes for breathlessness and identify what we could be dealing with. In today's talk, we're going to see how we can identify normal lung, identify pleural effusion, alveolar consolidation, interstitial syndrome, and pneumothorax. I'm going to start with some very basic points, and we are going to build on that. First of all, these are the common probes which are seen with the ultrasound machine. Out of these, the probes that we generally use are the sector probe, convex probe for imaging of the lung. Linear probe is generally used for for imaging of the vascular structures. When we talk about lung ultrasound, you would have heard about the Blue Protocol. Blue Protocol stands for the bedside lung assessment, bedside lung ultrasound in emergency. And we will go to that eventually. But my focus for today's talk is that when you put the probe to the chest of the patient, you're able to identify what you see and not necessarily classify it that this is A profile, B profile, but you but you correlate the findings clinically, and it helps you in making a clinical diagnosis. So we have to first of all identify the points where we have to put the ultrasound probe, and we have to identify the upper blue point, lower blue point, and flaps. The way to go about this is that we put our two hands side by side with the thumbs overlapping, as you can see in the picture, and the center of the upper hand becomes the upper blue point, and the center point of the lower hand becomes the lower blue point. And when you trace the lower blue point posteriorly in a horizontal line, the point of intersection of that line and posterior axillary line becomes the flaps point. Flaps stands for posterolateral alveolar/pleural syndrome. Now, how do we put the probe to the chest of the patient? We can either put it longitudinally or transversely. But the longitudinal scan, look at the picture on the left of the screen. This is the scan where we will get the typical profile, and we find the typical lung findings of BAT sign. You can see on the picture on the right side that the reverberations of the ultrasonic waves goes till the bottom of this towards the depth. Well, on the top, you have the BAT sign. I will further elaborate it in the next pictures. But if you put it on the transverse manner, then you are going through you're longitudinally, you're going in between the ribs. So it is not as effective. And the best way to identify the structures is to put the probe longitudinally and to identify the standardized signs. There are 10 basic signs. We are going to begin with the top 3 signs, that is the BAT sign, the A line, and lung sliding. These are the signs which are seen in normal lung, followed by the quad sign and the sinusoid sign. These are seen in pleural effusion. Then we have the tissue-like sign or the shred-like sign. This is seen in consolidation. And the B line seen in pulmonary edema. Then we have the stratosphere sign and the lung point seen in pneumothorax. This is as we just discussed. Now coming to the first sign, that is the BAT sign. We are able to see a bat-like structure here when we probe the probe in a transverse manner. Let me go back to that slide so you can remember that. When we put this, we have the probe in the transverse scan and we have the longitudinal scan. When we put it in the longitudinal scan, we are able to see the BAT sign. Can you identify the bat-like structure at the top? The ribs are forming the wings of the bat, and the pleural line is the body of the bat. Here, you are able to see the pleural line, that is the lower line, and the upper and the ribs on the side which make the wings of the bat. This is the BAT sign. This allows you to locate the lung surface. Next, we look at the A line. So below the pleural line, you will find equidistant reverberations. These are the A lines. These indicate air, and A lines will be seen in normal lung parenchyma. So the A profile in the blue protocol is the normal lung profile, where you can find the pleural line, and there should be lung sliding, and you have the BAT sign. Talking about lung sliding, when the pleural line you see on the scan, when you find it to be glistening, it is because the two layers of pleura, that is the visceral and parietal pleura, they are rubbing against each other, and that is causing the lung sliding sign or the glistening pleura. And when you see this on the M mode, you will see the sea and sand sign. The lung parenchyma will be seen as granular sandy region, and above that you can see the muscular area, you find that as the C area, that is the straight lines, or also seen as the barcode, If you are able to see lung sliding, if you are able to see pleural line, if you're able to see the bat sign, and if you're able to see the A lines, these are the three signs which are signifying a normal lung, and this will define the A profile on the blue protocol. Next, we come to the signs of pleural effusion. First of all, here we have the quad sign. So this is an image which is formed between the pleural line. On the sides is the shadow behind the ribs, and beneath it is the lung line. So the area between the pleural line and the lung line on the sides is the shadow beneath the ribs. This quadrilateral area is suggestive of pleural effusion, and this is known as the quad sign. When you see the quad sign area and you shift it on the M mode, this is what you will see. This is a picture where on the top you have the sea, and beneath you have the shore, and in between you have dark anechoic area. So this area that is on the lower side, the lung line that you see, this is on the top of the shore. This lung line, when it moves with respiration towards the shore or towards the pleural line, this is what constitutes the sinusoid sign. Here you can see that the lung line moves towards the pleural line on inspiration, and this is where we can determine the amount of fluid as well. A 15 millimeter distance is the minimum required for safe diagnostic or therapeutic tap. Our next syndrome that we will be looking at is the alveolar syndrome or the lung consolidation. Here we find the tissue-like sign. So between the diaphragm, you can see that the lung, it also sort of mirrors the organ beneath. Sometimes when you put the probe at the flaps and you trace it downwards, at the junction, you will find liver, but if there is consolidation in the lower lobe, you will find that the structure or the character of image seen on ultrasound is very much similar to the liver characters. So this is known as the tissue-like sign, that the consolidated lung will begin to look like the organ liver. Next, we have the shred sign. So in the shred sign, what we saw earlier, we found that the pleural line is there, and beneath the pleural line, we found that there were A lines, and A lines were the normal lines. But instead of pleural line, beneath that, when you find lung lines, or you find lines which are broken, and from there some partial B lines are emitting. We'll talk about this later, the partial B lines. So when you find they are broken, this is actually signifying that this is the air fluid interface, which is at the depth, and this is characteristic of lung consolidation. So here we can see consolidation, and here we can also see on the right side the shred sign. Next, we are going to talk about B lines. Now, B lines are very important sign to be identified. In the picture, just see, we can see that the B line is which is emitting from the pleural line. So this is very important. If these lines which you see emitting from the pleural line were not emitting from the pleural line, but were coming halfway, like in this shred sign, these would be known as partial B lines. So the B lines are a type of comet tail artifact, they must arise or they arise from the pleural line. They are well defined, they are laser-like, they are hyperechoic, they do not fade along their track, they erase A lines as they pass through them, and they move with lung sliding. So using these characteristics, we can identify B lines. Now, B lines, after identifying them, if we are able to find 3 or more B lines between two ribs, then it is called lung rocket, and they define interstitial syndrome, which can be focal. But if we find diffuse lung rockets, and if we find lung rockets at the 4 points of the anterior chest wall, the 4 points being the upper and lower blue point on both the sides of the hemithorax, then that would define pulmonary edema. It can be hemodynamic or inflammatory. So here we see lung rockets, and we are able to see a patient with pulmonary edema. If the lung rockets are focal, then it could be focal interstitial syndrome. Now we will talk about pneumothorax. The first sign that we look for in a normal lung is lung sliding. And the first sign that is lung sliding, if it is missing when we put the probe to the chest of the patient, the first thing which should come to our mind is pneumothorax. So here we are seeing abolished lung sliding, and this is a sign of pneumothorax. And then we get the barcode sign, that is the sand and sea shore sign is lost and we only see the barcode. If we are able to find the lung point, that is the area at the junction between the pneumothorax and the lung, this is the most specific point or most specific sign for pneumothorax. Absent lung sliding, followed by the stratosphere or the barcode sign, followed by the lung point. This becomes absolute for a diagnosis of pneumothorax. Coming to the blue protocol. If we are evaluating a patient in the ICU, we put the probe to the chest of the patient. We first of all check for lung sliding. If the lung sliding is present, A lines are present, it is indicative of a normal lung. And in case, and it will be called a A profile. But if there is any evidence of DVT, say on Doppler or compression ultrasound, then it increases the suspicion for pulmonary embolism. If there is lung sliding and we find B lines or we find pulmonary rockets, then this is suggestive of interstitial syndrome if it is focal, or it is suggestive of pulmonary edema. If we find fractal sign or shred sign, then we think of pneumonia. And if lung sliding is absent, then we look for the lung point and we look to rule out or diagnose pneumothorax. The take-home message or the understanding is that ultrasound can help us. It is the point I want to make is that it is not secondary to chest X-ray. Chest X-ray is very good for documentation, but sometimes we do not have that much time. Patient is very sick in the ICU. And ultrasound really comes handy. The sensitivity for pleural effusion on USG is 94% and specificity is 97%. And you can look at these values. The sensitivity for pneumothorax is 95%, specificity is 94%. And it is fairly high, the sensitivity and specificity for diagnosing these syndromes on ultrasound. And I hope that more and more pulmonologists will use ultrasound that is commonly available in the ICU, and it will help them in their clinical diagnosis. Thank you. Thank you everyone for patiently going through with me, going through this webinar together. Now, over to Dr. Girish for his talk.
Good evening, everyone. I'm Dr. Girish Agrawal, consultant from Ramakrishna Care Hospital, Raipur. And today the topic I've been given is fluid assessment, its role of radiology in ICU for fluid assessment. Before the offset, I'd like to thanks Dr. Narender and Dr. Ravi Dosi for giving me this opportunity, and my moderator, Dr. Keerat. So, fluid assessment. Basically, it's a central component whenever we are assessing any patient of sepsis. Both hypervolemia and hypovolemia have their own side effect and drawback. But things to be remembered is not every patient who is fluid deprived is fluid responsive. It is only half of the patient who are fluid responsive. So there are various methods to assess the fluid responsiveness, right from the clinical parameters to the traditional methods. Then we have static parameters, we have dynamic parameters, but each and everything what we have been doing so far has got their own limitations. For example, statics are not reliable, dynamics are difficult to do, and clinical parameters, or for, let's say, for example, conventional chest X-ray, they are not up to the mark to assess the fluid assessment. So we need something more. And hence comes the role of ultrasound in the ICU. And basically what we'll be discussing today is how we can, with the help of ultrasound probe and echo, we can assess the fluid assessment or do the fluid assessment in an ICU patient. So points we'll be covering of the lung ultrasound, cardiac ultrasound, which will include echo and measurement of the IVC, RAP. Dopplers, there's a new inclusion of a Doppler in the assessment with hepatic portal renal Dopplers. Now let's see what is the role of ultrasound. If we are doing ultrasound, lung ultrasound, cardiac ultrasound, or looking at the IVC or looking at the Doppler, one point before we do it is to be kept in the mind is everything has to be assessed with the clinical scenario of the patient. None of this are actually replacement to the clinical judgment and assessment. They are all supportive to the clinical assessment. So always keep in mind first clinical, then the investigational part. What we do in the sonography is focused sonographic assessment of heart, abdominal vein, and lungs. Basically, what we call as a pump pipe leak approach. Lung ultrasound, Dr. Keerat has already spoken much about the lung ultrasound. I'll be just briefing how we can use lung ultrasound to assess the fluid statement. Basically, lung ultrasound, what we interpret are the artifacts. We don't interpret the structure, we are interpret the artifacts. Extravascular lung volume is an important indicator of fluid status, and with the help of lung ultrasound, this assessment has been a positive linear correlation between the PICO system, the pulmonary capillary wedge pressure system, and the radiological signs of fluid alert. So basically, it's a very good tool to assess the extravascular lung water. So we see that we can divide the patient as already been told. There's a 8-zone lung ultrasound has to be done to look for the evidence of pulmonary edema. And the zones are divided like this from the parasternal line to the mid-axillary line, 4 on each side of the chest. And on your right, you can see there are comet tails starting from the top of the image between the two ribs from the pleural surface, which is right hyperechoic image. And we can see the vertical comet tail going right up to the end of the image. So these are terms the B line, and they correspond to the curly B lines on X-ray. A positive B line region or zone is more than 3 lines between the two ribs, and if there are 2 or more positive regions, then it constitutes interstitial edema or pulmonary edema. But there are other conditions in which we can also have a B line besides cardiogenic pulmonary edema. There are focal pneumonia, ARDS, fibrosis, and contusion, and hence I said that everything has to be correlated with the clinical parameter. Coming to the lung ultrasound, it's a focus. We need to just have a minimum and practical approach when we are holding a echo probe or ultrasound probe to assess the cardiac function. We just need 5 windows, one of the parasternal short axis, one of the parasternal long axis, then the apical view, subxiphoid view, and IVC. These are the 5 view we need, and things we want to look in our ICU patients are function of the left and right ventricle. Is there any presence of pericardial effusion, tamponade, or there is an intracardiac mass? Is there any valvular disease, or what is the volume status? So this is how we move ahead. Basically, there are 2 different historical perspective of the pointer of the probe. Initially, when we started doing a scan in the ICU, it was a fast scan, and it was with the historical ultrasonographic with the pointer pointing the image, ultrasonographic image has a pointer on the left side. And with the recent advancement or the recent echocardiographic image, the pointer ultrasonographic image, the pointer is on the right side. So don't get confused with it. I will be just discussing how to hold the probe, where to give the pointer, and what you will see in the image. Okay, so let's start with paraexternal long axis view of the heart. So for the paraexternal long axis or short axis, for the both this, we need to place a probe on the second to third intercostal space, just on the external line or lateral to the external line. When we are doing for the long axis, marker of the probe should be towards the left elbow of the patient. And on ultrasound screen, as you can see on the right, the indicator will be on the left side of the screen. So left lateral, we can do this ultrasound while the patient is in the supine, but sometimes we need to change the position of the patient to the left lateral decubitus position. What we see on the paraexternal long axis is, on the top there is a right ventricle, then below the right ventricle is the left ventricle. Posterior to the left ventricle, we can see there is a pericardium lining. Anterior or superior to the on your right, you can see from the left ventricle there is a left atrium. Above left atrium there is an aortic valve, and below the left atrium there is a descending aorta. So this view we get whenever we hold a probe in the paraexternal long axis view. We always try to throw our ultrasound sonic waves on the longest axis of the heart possible, so that we can get a better image. Now, when we look at some of the pathology which we can see from the paraexternal long axis view, look at the calcification of the mitral valve. So the calcified mitral valve, they are hyperechoic mitral valve, more denser structure reflecting the sound back more forcefully and giving a bright positive image. Then we can see pericardial fluid, which is a liquid which cannot reflect sound that much, and hence is a dark anechoic view. Similarly, the pericardial fluid can also be seen. Then we can use a Doppler to see whether what is the flow of the blood, and then we can have we can also assess the left ventricle valve thickness to look for the left ventricular hypertrophy. Now, once you have hold the probe in the paraexternal long axis view, don't do anything, just rotate the probe to 90 degrees, so that now the marker, instead of pointing towards the left elbow of the patient, is pointing towards the right hip. And what we get is the view of the left ventricle and right ventricle. It's a tunnel view of the left ventricle and a fish mouth opening of the mitral valve. Now, if we pointer slightly superiorly and medially, then probably we will get an aortic valve outlet area with aortic valve, which is represented as a Mercedes-Benz valve. So this is how we can get the paraexternal short axis. Now, subxiphoid view is place the probe below the xiphoid, pointed towards the left shoulder with marker on the right side or the right elbow of the patient. And this is the view on your right, what we get in the subxiphoid view with RV, LV, RA, LA, and mitral valve. So the 4-chamber view, basically what we get in the subxiphoid view. In the paraexternal long axis, we cannot see the right atrium. In the paraexternal short axis, we can only see both ventricle and the outflow tract. In subxiphoid, again, we cannot see we can see all the 4 chamber. Now, coming to the apical view, probe should be placed on the nipple in case of male, or in case of female, just below the breast fold. Marker of the probe should be on the right side, and on the ultrasound scan, indicator will be on the left side, giving a classical view of the apical view. Note first, before placing the probe, you should feel the pulse, and when the feel of the pulse is the loudest or third is the highest, there we should place the probe. Points to be taken care of: LVH more than M. If the diameter of LV is more than 11 mm, indicates LVH. If the RV wall thickness is more than 5, it is a chronic RV failure. And during the systole, if the diameter reduces more than 1/3 of the diastole, then ejection fraction is more than 60%. So basically, we do not calculate anything. We do not apply any formula. It's just an eyeballing, looking at the wall thickening and motion. In general, LV wall should approximate 1/4 or more in the parasternal view. If there is a hypovolemia, wall thickening, and the inward motion is decreased. If there is a hyperdynamic ventricle, if there is a volume depletion, there is a hyperdynamic ventricle, which are giving a casing sign. And if there is a decreased LV function, the motion will be reduced. Chamber size is another thing which we have to assess while we doing the cardiac ultrasound. Normal ventricle cavity is about 2/3 of the left ventricle cavity. Apical 4-chamber and paraexternal short axes are good views to assess the ventricle size. D signs indicates overload of the RV, which results in the flattening of IVS during dystole, which can be seen in a fluid overload or in the pulmonary embolism, massive pulmonary embolism. Now coming to the right atrium, which is our concern because of the fluid status, what we are seeing. Right atrial pressure, IVC ultrasound is used to calculate the right atrial pressure. Now, IVC collapses with inspiration in spontaneously breathing patient, while in mechanical ventilation it distends. So, in spontaneous breathing patient, a collapsibility of more than 50% with correspond to the clinical scenario correlates well with the hypovolemia. If the IVC diameter is less than 2.1 and collapsibility is greater than 50% with sniff, it indicates normal RAP. But if IVC is more than 2.5 and 50% collapse, it indicates high RAP. Just a brief on the how we calculate or what is the physiology of the IVC. The transmural pressure of the IVC is the right atrial pressure, which is the intramural pressure transmitted to the IVC, minus the intra-abdominal pressure, which is an extramural pressure of the IVC. With inspiration, pleural pressure is transmitted fully to the atria and hence increase in the transmural pressure. So just keep in mind the reverse happens with the SVC. Now, distensibility index of the IVC in a mechanically ventilated patient can be calculated as the maximum diameter of IVC minus minimum upon the minimum diameter. And 18%, approximately 18% of the distensibility index indicates a good fluid responsiveness, or I will say hypovolemia status rather than the fluid responsiveness, with 90% sensitivity and specificity. Now, when we open the IVC in the subxiphoid view, the point where we need to measure the IVC is approximately 2 centimeters from the junction of RA to the opening of IVC. And more specifically, we can say that when all the hepatic vein merges with the IVC, just calculate about a 1 to 2 centimeter distance to that. And that's the point where the IVC should be measured. It is rule that plethoric non-collapsible IVC indicates venous congestion now, but it does not mean that the patient does not require fluid, or patient is not fluid responsive, or patient is not going to respond to fluid. There are certain conditions in which a non-collapsible IVC is still responding to the fluid challenge, like chronic RV dysfunction, myocardial infarction, and cardiac tamponade. Now, there occurs some while assessing the IVC, there might be some errors in the interpretation, like obese patient, surgical dressing, burns, increase in intra-abdominal pressure. So this all can lead to difficulty in the interpretation. Then there are factors which can change the IVC. That factors can be the luminal factor, right from the RA to IVC, the intraluminal, which include compliance, tricuspid valve, obstructed RA, photosystemic shunting. Then there can be some extraluminal factor like tension pneumothorax, spontaneous ventilation patient, mechanical ventilation, pericardial tamponade, intra-abdominal pressure. All can have a different effect on the IVC. Some may have a more IVC distensibility, some may have a collapsibility. Now, when we look at the cardiac ultrasound, disease specific, what finding we'll see. cardiac tamponade. For the best view to look at the cardiac tamponade is the apical and the subxiphoid view. And there is a diastolic collapse of the right ventricle that we need to see. There's a diastolic collapse of the right ventricle, which indicates that the pleural effusion, pericardial effusion is significant to cause the collapse of the right ventricle. In pulmonary embolism, again the parasternal long axis is the best view, followed by parasternal short axis. Then we can have various sign on echo, example McConnell sign or 60-60 signs, which can point towards the pulmonary embolism. So enlarged right ventricle on the parasternal long axis, dilated right ventricle with ratio more than 1, which indicates a McConnell sign. Then there's a flattened interventricular septum or the D-shaped sign. Then there's a distended IVC without any variation. Then there's a 60-60 sign. So various signs are there in the echo which can help in diagnosing pulmonary embolism. So best view for pulmonary embolism, parasternal view, whether long and short, along with subxiphoid, which can help, but be careful during the subxiphoid. Normally, RA appears to be dilated, RA-RV appears to be dilated, so you have to correlate with the parasternal view. Best are the parasternal view, tamponade, subxiphoid view, pericardial effusion, again parasternal long axis view. Coming to the Doppler, something new addition to the assessment of the fluid, hepatic vein Doppler, portal vein Doppler, and intravenous Doppler. Normal hepatic Dopplers is a pulsatile, and it consists of 4 different waves. However, only 3 can be seen. So there are 2 antegrade waves and 1 or 2 retrograde waves, and these waves correspond to the CVP wave. So the 2 antegrade wave, one is the larger systolic and smaller diastolic wave, which corresponds to the X and Y descent of the CVP respectively. And 2 retrograde wave, larger A and smaller V, which responds to the A and V waves. Frequently, V wave is not seen. So condition in which hepatic Doppler can be useful, that severe pulmonary hypertension will have a prominent A wave and a decreased D wave amplitude because of increase in the diastolic pressure of the volume. Now, to understand this, basically, we need to understand that whatever we are seeing in the IVC, it is a direct reflection of the right atrial pressure. So something which happens with the right atrium is reflected in the IVC. Now, the flow mechanism, the antegrade flow, the systolic and the diastolic wave, they occurs with the filling of the ventricle, and the retrograde mechanism when the ventricle pushes back to fluid to the IVC. So this way we can look at the RA, pulmonary artery hypertension, tricuspid regurgitation, all we can assess with the help of hepatic Doppler. Portal vein Doppler and intra-renal vein Doppler is basically to assess the AKI risk prediction, though portal vein Doppler has shown that with the help of portal vein Doppler, when we do the decongestive therapy, it has shown to have a better outcome and risk assessment with as far as AKI is concerned. But intrarenal venous Doppler is helpful in predicting the volume status, but intervention with the help of renal vein Doppler leading to significant improvement in the condition is yet to be assessed. Now, portal vein Doppler is not pulsatile, but it can be pulsatile in few conditions, and like severe TR, high systolic pulmonary artery pressure, fluid balance, and RV dysfunction. And there is again pulsatility index, which indicates how much volume status is there. As I told you about intravenous renal Doppler, so here what I was talking about is that in the hepatic Doppler, you have an A wave, S and D. So S and D, they correspond to the X and Y descent with the systole and diastole, and A is the retrograde flow. So just look how the severe TR with the hepatic vein and portal vein Doppler in severe tricuspid regurgitation, when there is a backward flow, A will become prominent, as can be seen, and the portal vein become pulsatile rather than the monophasic non-pulsatiles. So again, same about the interrenal vein. It is a continuous in non-congestive, biphasic in moderately congestive, and severely congestive in monophasic. So with the help of Doppler, either the hepatic Doppler or the portal vein Doppler or the intrarenal vein Doppler, they help in assessing the fluid status along with IVC. But IVC remains the most important modality, though all this modality are still coming up. to assess the fluid status of the patient. Portal vein Doppler and intracranial vein Doppler are more commonly for assessment of the AKI. Hepatic vein Doppler can directly correlate with the right atrial pressure and helps with, along with the IVC, we can have an assessment of the cardiac condition too. So how do we assess about the patient in shock? First of all, we stepwise approach, rule out the obstructive shock, simple cardiac sonography to rule out tamponade and the RV dilatation, and with the lung ultrasound, rule out the pneumothorax, which can rule out obstructive shock. For cardiogenic shock, apply the blue protocol to look for the pulmonary edema. For ruling out hypovolemic shock, again we come with the IVC and cardiac parameters, and then again we have a septic shock distribution. So fluid therapy may not able to improve circulation, eventually generating B profile, which can indicate that this volume is actually going to kill the patient. Thank you.
Thank you, Dr. Girish, for a brilliant presentation. It was a complex topic, but you navigated through it beautifully. I'm very sure that this particular video, when it goes on YouTube at the CCI official YouTube channel, people are going to visit it over and over again to absorb the concepts. Very beautifully done presentation indeed. Congratulations.
Thank you.
I would now like to open the Q&A session with a clinical case scenario. A 58-year-old patient in the ICU with spinal injury develops breathlessness and starts to desaturate. On auscultation, the chest it is unremarkable. ECG shows tachycardia, and the chest X-ray shows ill-defined peripheral opacity in the right upper zone. May I ask Dr. Nirupam, sir, how would you like to assess this patient?
Thank you for inviting me. Before I answer this question, first of all, many congratulations to you and Dr. Girish for excellent and fabulous presentation. Many congratulations. So again, now moving to the question, case scenario has been given to us. So first we will look on what are the host factor. She is 58 years old, so more than 50, and she is having spinal injury, so bedridden. And what are the symptoms we are given? She has developed a sudden onset breathlessness. So when a patient who is bedridden, more than 50 years old, and develops sudden onset breathlessness, so we have some DDs. So we go according to the differential diagnosis. First one is pulmonary thromboembolism, maybe pneumothorax, maybe anaphylaxis, airway obstruction, metabolic acidosis, flash pulmonary edema, arrhythmia, myocardial infarction, so on and so forth. So what are indication given to us? First one is ECG, which is showing tachycardia, and the catch is given in chest X-ray radiograph, which shows ill-defined peripheral opacity in right upper lobe. So what we will do now? So since this scenario is indicating towards pulmonary thromboembolism, so and the suspicion is high, so the need of D-dimer is not so much in this case. So we move on to the more specific test, which is CTPA. If CTPA is diagnostic, well, we have our diagnosis and we can start our treatment. But if it is inconclusive, we can go to another test, which is VQ scan, because we know that when the probability of pulmonary embolism is high, and if this CTPA is negative or inconclusive, the negative predictive value is very low, around 60%. So next test is VQ scan. And suppose VQ scan is also inconclusive, both are inconclusive, then the gold standard, which is rarely done, is pulmonary angiography, which is a very invasive test which can be done to make a diagnosis. In few centers, which has another test is there, we need to mention because it is an educational seminar. So that is magnetic resonance angiography, or venous phase, which is magnetic resonance venography, can be done, which has got very good sensitivity of 92% and specificity of 96%. But the technical challenge is there, so it is not routinely done. I hope I have answered your question.
Thank you, Dr. Nirupam. You have covered everything from CTPA to pulmonary angio to MR angio. But I would like to come to the basics. So I would like to ask you that what are the chest X-ray findings of pulmonary embolism?
Yeah. So this I remember from my PG days, when a case of pulmonary thromboembolism is there, the examiner will not let you go unless you say the two words. Those two words, which is very less frequent, I must say. One is Westermarck sign, which is focal oligemia proximal to the pulmonary embolism, and another which is mentioned in this case scenario is ill-defined opacity, peripheral opacity, which is Hampton's hump. The base is towards the pleura and the hump is towards the hyla, which is due to the pulmonary infarction. And there are many other abnormalities, but the chest X-ray is seldom diagnostic of pulmonary embolism. I would say that there may be cardiomegaly, pulmonary arterial enlargement. There can be linear atelectasis and pleural effusion as well present in all these cases.
Yes, sir. Thank you. This is, I believe, if this would be the answer in a Viva, full marks, definitely. So my next question is to Dr. Girish. So Dr. Girish, coming to the clinical aspect of pulmonary embolism, could you discuss the Wells criteria for the pre-test assessment of pulmonary embolism probability?
Yeah, hi. Thank you, Dr. Keerat. Wells criteria is a well-known pre-test probability test, and it is basically designed for an OPD patient and has to be interpreted very cautiously in the IP patient or sick patients. So basically, it has got 7 criteria, and the scoring system of the Wells criteria is depending on those 7 criteria. There are various number allotted to the 7 criteria. 2 of them have been allotted 3 score, 3 of them have allotted 1.5 score, and another 2 have been allotted score of 1. So the 3-point score has been allotted to the clinical signs of DVT, or if there is a less likely any other diagnosis. So both carries 3 points. Then there is a 1.5 score given to the 3 criteria, out of which immobilization or surgery in the last 4 weeks, which we have with our patient, heart rate of more than 110, and a previous DVT of pulmonary embolism history. Then 1 point allotted to hemoptysis or malignancy in chemo who has been under chemotherapy for the past 6 months. So basically 7 criteria, and as per the probability, it can be divided into low, intermediate, or high with a score less than 2 or more than 6, and intermediate falling between 2 to 6. But Wells criteria alone, though it can give a pretest probability, has to be subjected as per the clinical condition with the various other tests. If we apply Wells criteria and add testing either in the form of D-dimer or in the form of lower venous Doppler, or the invasive method in the form of either CTPA, PA, or VQ scan, it increases the probability of making a diagnosis. I think for the OPD patient, if there is a low clinical probability, score less than 2, a negative D-dimer alone is sufficient, though sometimes you may have to combine with a negative CTPA or a normal VQ probability scan. But in our case, if, as Dr. Nirupam says, if CTPA is negative, if the VQ scan is of intermediate probability, not a normal probability, then probably we need a pulmonary angio or as the advancement MR, magnetic resonance angio, we know RTO, या फिर the speckled PET scan, single positron emission, positron emission VQ scan. So these are the things which we can have along with the Wells criteria. Regarding the negative probability with the VQ scan, a negative VQ scan means there is no PE, but a negative CT pulmonary angio cannot rule out PE because the subsegmental branches may not be able, we may not be able to detect in the subsegmental branches, and those constitute approximately 1/3 of the patient load. So it's not that the major or the lobar artery is the only site for pulmonary embolism. The subsegmental branch, they constitute 1/3 of the clinical pulmonary embolism cases. So we cannot rely on CT pulmonary angio until unless we have a proximal artery thrombus. In that case, a VQ scan is really going to be helpful.
Thank you, Dr. Girish, for elaborating on that. I would like to acknowledge the questions and compliments and remarks that I'm receiving from the audience. Dr. Tridip Chatterjee, a very senior physician, consultant pulmonologist from Mumbai, he's asking that we stress on the bedside test. Yes, sir, this is the reason this topic has been chosen. And he's also answered the question, that is Westermarck sign and Hampton's hump. Yes, sir, full marks to you as well. And another query is from Dr. Jitendra Kumar Dhayalal Shah from Gujarat, Bayad. He's asking how to view previous videos of CCI, including this. So this is for everybody's information that CCI Official, this is the name of the official YouTube channel, and all the previous YouTube webinars have been uploaded over there, and you can access them anytime. This will also be uploaded, today's video will also be uploaded within the next 24 hours. So I would now like to come to Dr. Nirupam. So sir, coming back to the tests which we are actually dealing with, what are the direct and indirect signs of pulmonary embolism on CT pulmonary, CTPA?
Well, the direct sign, as you see, the most important is the filling defect within a opacified pulmonary artery. It can be completely occluded vessel, or it can be a rim of contrast surrounding the embolus, which can be viewed as a tram track when viewed parallel to the scan plane. Or another direct sign is chronic emboli, which may recanalized and can appear like a concentric thrombi, which is subjacent to the arterial wall. And there are few indirect signs as well, like there is a reduced caliber of the vessel distal to the embolus. There, as we have already discussed, the infarct, which is peripheral consolidation with regional heterogeneity and ground glass opacity. And that can be in chronic thromboembolism, a mosaic attenuation pattern due to the heterogeneous perfusion. So I think these are the direct and indirect sign on CTPA.
Very correct, sir. And taking this further, Dr. Girish, what are the signs of severity of pulmonary embolism?
Well, when we are saying about the severity of pulmonary embolism, I cannot stop just looking at the severity. I have to also look at the mortality, because severe or a massive pulmonary embolism, no matter whatever intervention you do, it carries a high mortality, approximately 30%. 1/3 of the patient with a severe pulmonary or massive pulmonary embolisms are going to die despite your intervention. So massive embolism or severity embolism, we can have different view on that. So first is, if there's a hemodynamic compromise, it has to be a severe pulmonary embolism. Then there are intracardiac thrombus. They can be a severe embolism or submassive pulmonary embolism. Then you have a severe right ventricle dysfunction, but they do not have any hemodynamic compromise. So they can again be classified as a submassive pulmonary embolism. Now, if we are looking at the clinical parameter, then hemodynamic instability is the only thing which needs intervention. Though you can have intracardiac thrombus with the help of surgical colleague, and if there is a severe RV dysfunction, and if you think that this is going to convert into severe pulmonarism, then we can have some objectivity to that severe RV dysfunction. We know that size of the ventricles, the left and the right ventricle, left is larger and the normal ratio of the right to left is 0.6. But if the size increases to 1, the mortality increases. And if the size ratio is 2.3, if RV is 2.3 to the LV, then it is a severe mortality factor. So in a patient of severe RV dysfunction without hemodynamic instability, if the size ratio falls somewhere from 1 to 2.3 or more than 2.3, it should also be considered as a severe pulmonary embolism.
Right. So we look at the RV ratio, and this is one of the signs. Otherwise, we look at the echo and we get all the other parameters.
Yeah.
So I would now like to ask the radiologist on board, Dr. Nikhil Gupta. Dr. Nikhil, we generally get a lower limb Doppler when we are suspecting pulmonary embolism. I want to ask you that when should we go advise a CT venography, or what is the role of CT venography in a patient with pulmonary embolism?
Good evening, everyone. Thank you, Dr. Keerat, for the question. I would first like to thank Dr. N.H. Krishna and Dr. V.K. Chennamchetty for giving me this opportunity to be here. Now coming to your question, I would like to say that in cases, first of all, where lower limb Doppler cannot be done, like there is a venous ulcer or open wound over the leg, very important, we can't do the Doppler, and then patient is not willing for the Doppler, very important, as we have to disrobe the patient for the procedure. And then there is like patient is unable to move because we have to look on the posterior side of the legs as well. So those can be missed, or the Doppler is not conclusive, or we have a finding, but we are not sure about that finding, so that we have to confirm it on the venography. Like, for example, the patient is posted for CT pulmonary angio, and on pulmonary angio, we get a thrombus. So in the same sitting, we can do the venography after 75 to 90 seconds of that contrast injection followed by bolus, and we can take it on the table same time. Or we can plan like CTPA plus venography, so that the patient has not is not to be shifted twice for this procedure, because it can be taken in one sitting only. So I hope it answers your question.
So you've answered my question, but here's what I would like to ask you again. If we have gotten the Doppler done, so is this what you would want or expect from the pulmonologist or from the ICU team? That if the Doppler is negative, because the same radiologist may not have done the Doppler ultrasound for the lower limbs, should we send in that along with the? Should we send in that documented with the request for CTPA that the Doppler lower limbs is negative and for DVT, so that the radiologist can then go in for CT venography while they're assessing the thorax?
In that case, yes, it is definitely helpful. And if we see a proper thrombus on the chest, we generally go ahead and do the venograph.
Also, it would decrease the radiation exposure.
No, it won't decrease the radiation exposure. It would just decrease the number of visits the patient has to do in the CT room from the ICU.
Then compared to getting a separate venograph.
Yeah.
All right. So thank you very much for that answer. I would now like to ask Dr. Nirupam Sharan. Dr. Sharan, coming back to VQ scan, when would you like to advise a VQ scan in a patient?
Yes, there was a study of around 776 patients known as PIOPED-2 study, which is a prospective investigation for pulmonary embolism diagnosis, which clearly investigated the severe different modalities of diagnosis of pulmonary embolism. In that, they found out that in low to moderate clinical risk of CTPA, the CTPA had a negative predictive value of around 89 to 96%, which is the true negative. If there is a high clinical risk and the CTPA is negative or inconclusive, the negative predictive value is very low as 60%. In those cases, you need to rule out with another test, which is also very good, which is VQ scan. So in these cases, VQ scan is advised to make the diagnosis. And another point can be it is also very debatable, because in a pregnant pulmonary embolism suspect patient with discussion and all those things, VQ scan is preferred more than CTPA in those patients, because it has got more radiation exposure, and only Q scan can be preferred, which gives you less ionizing dose of radiation.
Thank you, Dr. Nirupam. May I now ask Dr. Girish to elaborate the considerations in a pregnant patient when choosing between CTPA and VQ scan in a suspected case of pulmonary embolism, and obviously with no conclusive diagnosis as yet. So what would be the considerations? Please unmute yourself, Dr. Girish.
In a pregnant patient, before jumping to CTPA or VQ scan, I think clinical probability and Doppler should be the first investigation of choice. If then also we have to land up in a controversial CTPA versus VQ in pregnancy, I'll prefer VQ scan. The reason is radiation exposure, amount of radiation which has been exposed in CTPA versus VQ scan, approximately 7 times. So if VQ scan radiation is 0.1 millisievert, it is 7 in CTPA. And this exposure is more to the maternal, to the mother than to the fetus when we do the CTPA. But with VQ scan, particularly in late pregnancy, exposure is more to the fetus. So it's like flipping a coin. We should we have to decide by that method. But I will prefer VQ scan, because CT again increases the chances of breast cancer in females, and the chances of fetal cancer though is high with VQ scan, but it is still very less. So I think VQ scan would be the right choice.
Thank you, Dr. Girish, for your take on that. Now moving on, I would like to ask Dr. Nikhil. Dr. Nikhil, how would you evaluate a patient with new onset breathlessness in the ICU? How do we make the best use of the radiologist?
Yeah, instead of making best use of a radiologist, you might like to make the best use of the ultrasound machine lying there, right? While you are awaiting the chest X-ray film, which nowadays comes in like 5 to 10 minutes. we can be able to rule out pneumothorax, pleural effusion, pulmonary edema, cardiogenic or non-cardiogenic type, or pneumonia or collapse on the ultrasound. Yeah. So that would be bedside, quick, and maybe you don't need a radiologist after all for that.
We will still need a radiologist, but thank you for that. So I would like to ask you another question, Dr. Nikhil.
Yeah.
In a patient who can't sit for or stand, or in a patient where we can't get an erect chest X-ray, what is the best position to get an X-ray to rule out pneumothorax?
For pneumothorax, though, the best is standing X-ray or erect X-ray or sitting up X-ray, because air rises up, as you know. So a lateral decubitus with the affected side up will give you a better assessment.
Thank you. And what are the common causes for a false positive, or say a false impression of pneumothorax on chest X-ray?
One very important is the skin folds. Air trapped under skin fold, a very obese patient, and we see it as a pneumothorax because it is lying laterally to the lung and there is no vascular marking within it. So a skin fold will be one very important. The second would be bullae, large or small. So they can also mimic pneumothorax.
Right, that's very commonly found, and you're right. And I think that's sometimes we've even seen that CT scans have been ordered because somebody misdiagnosed it as pneumothorax on a chest X-ray.
Right.
May I now come to Dr. Girish? Dr. Girish, after your wonderful presentation, this question is for you. What is the role of cardiovascular ultrasound assessment in the ICU?
Well, extensive. Means it's a handy tool, and diagnosis in minutes, rather seconds. You can rule out virtually cardiogenic shock, obstructive shock, distributive shock, hypovolemia status. You can have cardiac echo guided pericardiocentesis. It can help. It is very helpful in pulmonary embolism. Today, it's a case of today only. I had this patient of pulmonary tuberculosis with. He was on a ventilator, respiratory failure with Ramson aneurysm, coiled at 5 different levels with bronchial artery embolization. In the morning, he was hemodynamically stable on 50% FiO2. By afternoon, he had 3 vasopressors and 100% FiO2. I did the echo. There was a dilated RA. We confirmed with the IVC and everything, thrombolized the patient. Unfortunately, could not save the patient. But it's quite handy. Means hardly within 10 to 15 minutes of onset, everything was done. So it's quite handy, extensive, very friendly tool. I would say that.
I'm sorry that the patient did not survive, but the fact that you were able to do so much without moving the patient out for further assessment, isn't that remarkable? And
yes.
that answers the question that how we can actually use it to the fullest.
Yes.
Maybe at least to whatever level we can understand to use it, we should use it.
Definitely.
So coming to this only, that what are the signs of volume depletion which can be seen using an ultrasound?
So let's separate it in a spontaneously breathing patient and mechanically ventilation patient, because the respiratory physiology reverses. So when we talk about the spontaneous breathing patient, IVC in the spontaneous breathing patient, they collapses in SVC distance. So it's the reverse of IVC and SVC in spontaneous breathing as well as in mechanical ventilation patient. So when the spontaneously breathing patient, if we are looking at the IVC level, and if the IVC is less than 2.1 centimeter with more than 50% of collapsibility, so it's a normal with the normal RAP and normal everything, right? But again, if it is collapsing to more than 50% and IVC diameter is more than 2.1, so it's a plethoric IVC, and probably it's no use of fluid assessment. It's a hypervolumic state. Similarly, in the mechanical ventilation patient, if we are looking at the fluid assessment with the help of IVC, normally variation is subjected to look for the fluid responsiveness. If we look at the IVC distensibility index of 18%, so that indicates the fluid responsiveness. But sometimes there is we can just see a plethoric congested IVC, right? And the plethoric congested IVC with pulmonary edema picture also on the lung ultrasound, and we tend to think if fluid is going to be helpful or not. So there are few conditions in which still fluid can be of helpful in this patient, particularly RV infarction, or if there is a cardiac tamponade. So complete assessment solely on the basis of IVC should not be done, as I have already talked in my talk, that it has to be correlated with the clinical presentation, the clinical assessment and judgment.
So, taking this assessment further, fluid assessment, what is the correct site for IVC diameter measurement on the MO?
In the subsequent view, when we open the IVC, we should make sure that the view which we are getting has a direct connected. The RA is connected to the IVC. There should be it should all be opened, and from that junction, 1 to 2 centimeter beyond that junction towards the IVC is the correct site, because in that 1 to 2 centimeter hepatic vein drains in the IVC. So what the IVC site is approximately 1 to 2 centimeter from the junction of right atrium and IVC opening.
Perfect. So we have to trace the hepatic vein junction with the IVC, and in that view, we should get RA as well. So we can trace from the RA, or we can 1 to 2 centimeter from the RA, or we can trace from the hepatic vein and IVC junction onwards towards the RA.
Yeah.
Perfect. And I would like to ask you, this is a question which has popped up several times from the audience. What is the difference between IVC collapsibility index and distensibility index? I think we need to, I would like to elaborate on the concept.
Basically, for understanding the concept of IVC collapsibility, we need to understand the cardiopulmonary interaction. Right. So during normal breathing, it's a negative pressure breathing. When we inspire, taking inspiration, there's an increase in the negative intrathoracic pressure, and fluids are pulled up or sucked up, which leads to the collapsibility of the IVC. So a spontaneous breathing patient with inspiration, the IVC collapses. Now, when we turn to positive pressure ventilation, when we shift from negative pressure ventilation to positive pressure ventilation, the intrathoracic pressure is increased. Everything becomes a closed compartment. They works in a series. Everything becomes a closed compartment. And when the machine pushes the inspiration, the thoracic cavity expands, and as a result of that, there occurs a distensibility of IVC because the pressure is transmitted, the right atrium pressure is transmitted. Now, to understand this also, we need to understand the transmural pressure of the right atrium. So the transmural pressure of the right atrium in a positive pressure ventilation and in a negative ventilation or spontaneous ventilation, how we calculate the transmural pressure of the right atrium? The transmural pressure is intramural minus the extramural. So RA pressure, which is the intramural pressure, minus the surrounding pleural pressure, which is the usual external pressure. With negative pressure ventilation, as we inspire, there is a negative pleural pressure is increased and intramural pressure decreases. As a result, the fluid is sucked. But with positive pressure ventilation, there occurs an increase in the transmural pressure, and it transmits down to IVC, leading to the distensibility. So the reversal of cardiopulmonary interaction in normal spontaneous breathing and in positive pressure breathing has to be understood in a very finer way, because when we elaborate the concept of transmural pressure from the RA, RV, LA, LV, what we'll see that with the positive pressure ventilation, the RA preload is decreased, RA afterload is increased, but at the same time, LV preload is increased and LV afterload is decreased. So it's not just a matter of IVC collapsibility, which happens in spontaneous pressure ventilation, versus IVC distensibility, which occurs in a positive pressure ventilation. It has to be looked in series how it affects the cardiac output also.
Right. I think physiology is one part that you have wonderfully explained, but for everyone to remember, in a spontaneously breathing patient, when you're documenting, you would document it as the collapsibility index. And in a patient who is mechanically ventilated, you would document it as a distensibility index. My another question to you, Dr. Girish, is that what is the best view to look for pericardial pathology?
Well, there are different. You mean pericardial pathology means pericardial effusion?
Effusion, just to check for quick eyeballing.
Quick eyeballing. Okay, so apical view and parasternal long axis.
Basically, apical or the four-chamber and
the four-chamber and parasternal long axis. From subxiphoid view, okay, so subxiphoid view is also helpful in this patient if the amount of pericardial fluid is less. So in that case, a subxiphoid view will be helpful. But again, there is a catch when we are looking at the subxiphoid view. We need to differentiate between the pericardial fluid and ascites, if the patient has ascites also. So in subxiphoid view, it can be confusing whether it is in pericardial fluid or whether it is ascites. So there are echo criteria for that. If it is subcapsular or it is beyond the capsular or it has been surrounded by liver and all that. But have a catch on that it is to be confused. It should not be confused with ascites.
Right. Coming to Dr. Nirupam. Dr. Nirupam, how to differentiate between cardiogenic and non-cardiogenic pulmonary edema?
Well, to answer this question, we must understand the pathophysiology of pulmonary edema. As we all know that pulmonary edema, by definition, is excess of fluid in the extravascular lung space, and it can be caused by two phenomena. As per Stirling law, one in a cardiogenic pulmonary edema where the hydrostatic pressure within the lung capillaries are increased due to fluid overload or cardiac dysfunction. Secondary, as we see in non-cardiogenic, there is an increased capillary membrane permeability, and which is caused by variety of insult to the microvasculature of the lung. And when we see a non-cardiogenic pulmonary edema, all those signs of cardiac dysfunction or fluid overload are missing. And we see commonly the alveolar fluid accumulation, which is seen as a ground glass bilateral symmetrical opacity. And when we see a cardiogenic pulmonary edema, the first and the earliest sign is the vascular redistribution, which is also known as cephalization. And it can be seen in the upright X-ray, and which is very difficult to illustrate on the semi-supine or supine position. As the hydrostatic pressure increases, many other signs occurs, which are like appearance of curly lines, curly A, B, and C. Most prominent is the curly B line. And then you can appreciate the peribronchial coughing, loss of vascular definition, thickening of fissures, and as well as pleural effusion. So this will differentiate you between cardiogenic and non-cardiogenic pulmonary edema. Thank you.
Thank you, sir. So I would like to ask this question from our radiologist. This is a question from Dr. Muhammad Abdul Bais from West Bengal, from Dhaka. He's asking, can handheld ultrasound be as practical as conventional focus?
Handheld ultrasounds are actually, in my experience, I have never seen one.
So we use sonocyte in the ICU, most common, or even in the ER. I think that's the portable ultrasound. But the handheld ultrasound, I've also only seen the Gynac for the FHS on all only to see. I'm not sure, Dr. Muhammad. Maybe you can elaborate on the question again. And another question he's asking is that, considering dynamic fluid volume, so this is a question for, I think Dr. Girish can take it. Please comment on the other indicators you look for bedside in the IVC. Actually, I would like to take this further and ask you that I just asked about the pulmonary edema being cardiogenic and non-cardiogenic from Dr. Nirupam. So Dr. Girish, what would be the markers or signs of elevated right atrial pressure on echo? You need to unmute yourself, please.
Sorry. Well, one is the IVC, as we have seen, with the diameter is spontaneous breathing patient. But if we are talking about ventilated patient, then it is solely on the basis of IVC, assessment of the RA is very difficult. Right, so there are many factors for that, as we have already discussed some of the luminal and extraluminal factor which can affect the IVC or RA diameters or RA pressure. So if the IVC is approximately 10 to 12 mmHg, we can say that it is a normal CVP of our RA pressure of approximately 10. But if is there actually increased RA pressure, then I think besides IVC, I would also like to take the help of hepatic and portal Doppler, because we have seen that in hepatic Doppler, the antegrade A wave, the retrograde A wave, it shoots up whenever there is an increase in RA pressure. So whether it is a TR, whether it is a RA mass, or whether it is a chronic pulmonary artery hypertension, whatever, the pressure which is transmitted from right ventricle to RA to IVC to hepatic vein. So the hepatic vein Doppler, they will have a retrograde waveform, enhanced retrograde waveform. That is the one thing with RA on the hepatic vein Doppler. And then portal vein Doppler. So portal vein Doppler again will become pulsatile. Usually portal vein, there is splanchnic circulation, they are isolated from the systemic circulation. So it will become pulsatile. And as I've talked in my topic, that the pulsatility index of less than 30% or more than 50%, they can indicate from the mild to severe congestion. So along with IVC, in mechanical ventilated patient, looking for the Doppler is helpful in assessing that, okay, this patient may not be fluid responsive or it is overloaded.
I hope you have, I think you've adequately answered Dr. Muhammad Bais's question. My next question, I would still try to stick to the basics. So I would like to ask Dr. Nikhil. Dr. Nikhil, what would be the lung ultrasound findings when in a case of pulmonary edema?
As beautifully explained by you in your webinar before this talk, pulmonary edema, so B lines and lung rockets are essentially seen in the pulmonary edema. The 7 points of the B line, that it is comate tail and a pleural line, hyperechoic and well-defined long, and it erases the A line, and it is associated with lung sliding. So that is seen in pulmonary edema or lung rockets, that is 3 or more than 3 B lines in a space, in an intercostal space.
Right. So I think this is one of the easiest signs that any pulmonologist or any intensivist should be able to pick up in the ICU. And my next question again is to pertaining to the fluid assessment part, and this is for Dr. Nirupam. Dr. Nirupam, can a patient who is fluid resistant still have an inappropriately collapsing IVC?
Yes, this can be seen in few situations. Either the patient is inspiring excessively, or there is intra-abdominal pressure is abnormally high, as it occurs in ascites or intra-abdominal hypertension, portal hypertension, or when there is a low venous return and low cardiac output as well. Where there are many situations in which both the venous return to the heart is low and the cardiac function is relatively impaired. Like, for example, with poor venous return is cirrhosis, sepsis, or patient is on a venodilator medication or in adrenal insufficiency. And along with that, the patient is having poor cardiac function.
Thank you, Dr. Nirupam. Thank you very much. My next question again is to Dr. Nikhil. Dr. Nikhil, what about dealing with a patient with surgical emphysema? How should we, get cautious with lung ultrasound while doing a lung ultrasound in a patient who has surgical emphysema?
In subcutaneous emphysema, generally, we see lines similar to B lines, but not arising from pleura, like elsewhere in subcutaneous plane or somewhere else. So those are known as E lines, right?
Right.
So these are seen in the subcutaneous emphysema.
So we have, I think, 3 things that anyone should be able to identify is that B lines, which are arising from the pleura, sub B lines, which are not arising from the pleura, but are arising from the lung line, or in when you're dealing with a shred sign. So they are randomly appearing at the points of air and fluid interface. And third, E lines. E lines are that instead of arising from the pleura or from the lung line, pleural line or the lung line, when the lines, they start emitting from the or appearing from the subcutaneous layers randomly. So these would be the E lines, and they would be indicative of subcutaneous emphysema. Another question I would like to ask you, Dr. Nikhil, is we talked about lung point. What is lung pulse?
Lung pulse is used for immediate diagnosis of atelectasis. It is seen like reduction in the sliding with pulse transmitted from the heart. So generally, it is that.
My next question is to Dr. Nirupam. Dr. Nirupam,
Yes.
we as pulmonologists have done hundreds of pleural taps without ultrasound guidance. At least I have. So, and I believe we have all done, at least in our residency, hundreds of taps without ultrasound guidance. But do you think that the time has come that USG guided taps should become a standard protocol?
Yes, we all have done. Like I was trained in a government medical college, so many a times, initial days, ultrasound was not available, and if it was available, a long wait time was there. And if a patient is having moderate to large effusion, you need not need a ultrasound guidance. Only use your auscultation and percussion method, and you can tap. But when the challenge is there, when the fluid is less loculated, fluid is there, minimum fluid is there, but to be precise and to cause less injury to the underlying tissue, you must need ultrasound, which will guide you to the perfect tapping, which will save the patient from injuries. And also you can assess how much fluid is there left after the diagnostic tap. And you can see there is no bleeding, no damage to the surrounding structure. So I think the ultrasound guided tap is better than blind tap, and the protocol must be set for that wherever it is available.
I think, sir, you have very well spoken. And Dr. Girish wants to come in. Dr. Girish, may I? I'll just let you come in. The thing is, not just to save the patient, but also to save ourselves from litigation, to save the pulmonologists from the litigation. If an ultrasound machine is available, one should use it. Yes, Dr. Girish, please.
Yes.
Yeah, my question. I have another question on the same topic. How many times we have been refused by radiologists that the fluid is not tappable, and we have done blind tapping, and we have done blind tapping, and we have extracted the fluid. So I have done it many times, but for that I need a CAT scan, right? If I have a CAT scan with me, if radiologist is saying it is not tappable, I have done many times, despite being there, they say not tappable, I have tapped many times. Now the point is what we are discussing, that should it be mandatory? So consider a scenario where ultrasound guided tap is being made mandatory, and the sonologist or the radiologist is saying it is not tappable. So what should be the take on that?
I think the fact that there was this very famous litigation in Mumbai, in Maharashtra, I think it was Mumbai, Dr. Hegde or somebody. Yeah.
Dr. Ashit Hegde, yeah.
Yeah, so he had done a procedure. I think it was a tap or maybe a chest tube insertion. And there was pleural tap, and there was splenic rupture.
Yeah.
And they said that the ultrasound equipment was available in the vicinity. So that was the point. If it is not available, you can say it was not available, and the pulmonologist is the expert. He has the skill set to do what is required. But the fact that, but when it's also in the corporate sector nowadays, I think from the litigation point of view, we
from
even
the litigation,
that ultrasound guided it was done under aseptic precautions. No, so it is a standardized thing. Yes, because of litigation, if you're confident that you can do it, I think it should not be mandatory. But yes, given the scenario,
my only question was, if we make it mandatory, then what about those case scenarios?
Yeah, I think we would be encouraging more litigation in that case, because we're actually giving it away to them that if it is not guided, then we are tying our pulmonologists' hands by doing that. So it might not be the right. I mean, it's not that easy to take a call on this. We have to keep the patient's best interest in our mind, but we also have to understand that limitations of the medical infrastructure in our country. Not every center has an ultrasound. So yes, we have to have a wide approach. So here's this question from Dr. Ajay Lanjewar, Maharashtra, Nagpur. How to differentiate a collapsed lung due to fluid versus consolidation collapse? So, Dr. Ajay, first of all, the findings of fluid, due to fluid, if there is a collapse, we will be able to see the fluid, we'll be able to see the collapse sign, fluid would be superficial. Beneath that, we will be able to see the lung line, and from there would be emitting the partial B lines. So that would be one. Second is the lung pulse that Dr. Nikhil just elaborated. My next question is to Dr. Nirupam. Sir, what is the role of ultrasound in airway management?
Role of ultrasound in airway management, there are numerous roles. Means when you do a procedure which is blind, and when you do a procedure which is ultrasound guided. So the first one is the assessment of diameter of the subglottic upper airway, which predict you the size of endotracheal tube. And as we all know that the exact size is how much important for ventilating a patient. Then there is we can predict the difficult laryngoscopy in obese patient. The ultrasound measures the anterior neck soft tissue from the anterior aspect of the trachea as at different level, the level from vocal cord, from thyroid isthmus, from the suprasternal notch, and then we can assess the difficulty in laryngoscopy. There is the role of ultrasound in percutaneous dilatational tracheostomy. It accurately identifies the anterior neck structure and thereby eliminating the serious hazard as like hemorrhage, tracheal stenosis, thyroid injury, mediastinal vessel injuries, and then another utility can be the prediction of post-extubation stridor in this type of patient by assessing the laryngeal ultrasound, assessing the vocal cord, and next we can do a elective transtracheal cannulation or emergency cricothyroidectomy in this patient by ultrasound guidance. We can also see that ultrasound guided upper airway anesthesia can be given in a ABAC intubation. In this, we just localize the superior laryngeal nerve, which lies between the hyoid bone and the thyroid cartilage. Another utility can be endotracheal intubation or double lumen bronchial tube placement in this patient under ultrasound guidance. And we can also detect the laryngeal mask airway position by ultrasound. And we can also, when we are planning for nasal intubation, we can see the nasal pathology with the help of ultrasound. The most common is the maxillary sinusitis, which can help us to decide upon the course of the intubation. Thank you.
Thank you, Dr. Nirupam. And now newer protocols are even coming up for endotracheal intubation, which is UST guided. So they actually tell you how to see the cartilage and the pearls. They count the pearls. That's one of the structures you see. And we are now even having workshops which are on which are guiding regarding the protocols for ultrasound guided intubation. My next question is to Dr. Nikhil Gupta. When would you suspect pleural effusion on a supine chest X-ray?
When there is blunting, first sign is blunting. Second sign is there is a meniscus seen, right? Like on around 100 to 150 ml blunting can be seen, and around 200 ml the meniscus is seen. And if it is more than that, like 500 ml, then it obscures the hemidiaphragm.
But this would be in an erect patient. What if the patient is supine chest X-ray?
In a supine chest X-ray, the fluid will actually cover the lung, basically. So we can see the lung through the fluid. So it is hazy lung, like veil-like opacity, and preserved vascular markings because we can see the lung through it. And there is loss of clarity of the ipsilateral diaphragm. These are the signs of a supine X-ray.
Right. And when would you, Dr. Nirupam, when would you suspect subpulmonic effusion?
Yes, when a patient comes to you with complaint of pleuritic type of chest pain, and we do radiographic examination of that patient, we find that there is an apparent elevation of ipsilateral diaphragm. That is one catch to the point. There is also a shift of apex, the hemidiaphragm from the medial to lateral third. That can be flattening of medial aspect of the diaphragm. Or there is non-visualization of lower lobe blood vessel below the diaphragm. The distance from the apparent diaphragm to that of fundus gas is increased to the left. or you can subject the patient to the lateral decubitus view, which is extremely valuable to examine subpulmonary effusion, which can detect as low as 5 to 10 ml of effusion.
Thank you, Dr. Nirupam. And I would like to announce that as of 8:45 p.m., we had 914 logins. And over to Dr. Nikhil, I would like to ask you that can we differentiate pleural effusion from empyema and empyema from hemothorax on CT chest?
Yeah, it is though it is very difficult to do this, but in typical cases on CT, the empyema shows specific sign like split pleura sign. That is on the pleura is thickened and the visceral and the parietal pleura is separated, and we see the fluid in between those. So it is the split pleura sign. And on contrast, CT, we see enhancement of the pleura. So that is how we see empyema. In hemothorax, it is slightly like the HU value is like 30 to 70 HU, which in case of pleural fluid is less than 20. Or and also we can the difficulty arises when there is lung abscess versus empyema. So that is another thing. So which we differentiate on CT. And in like in the lung abscess, it has a thick wall, but it shows an acute angle with the pleura, that is claw sign, and has irregular inner wall, which is smooth in case of the empyema. And there is obtuse angle with the pleura in the empyema. However, on ultrasound, it is easier to differentiate between these entities. Like in hemothorax, we have the plankton sign. That is swirling opacities in the anechoic pleural fluid. And there is hematocrit sign, which is interface. There is an interface, or there is like echogenic contents within the pleural fluid. So on ultrasound, it is easier to differentiate hemothorax from others.
We generally do that in the ICU. If we find ecogenic material, if we find the septations, and we assume that it would be exudative, but I don't think we are able to say if it is hemorrhagic or or not. So I would like to ask these. I would like to take up these questions from the audience. I tried to take them randomly in. So Dr. Ajay Lanjewar, Maharashtra, has asked the question regarding Wells criteria, which already Dr. Girish has answered. And then there's a question from Dr. Subramaniam Sharma, Isukapalli, Maharashtra, Nanded. He's asking how much he or she is asking how much time it takes for RA-RV dilatation if pulmonary embolism is suspected. As I understand, it depends on the size of embolus and the embolic stress it creates. Next question is Dr. Ahmed S. from Tamil Nadu, from Chennai. He's asking about the acute intervention treatment in pulmonary embolism. Dr. Ahmed, we are not taking up talking about treatment protocols in this webinar. It is beyond the scope, so we are sorry. But we are going to quickly take up as many questions. Dr. Tridev is again, Chatterjee is asking from Mumbai, Maharashtra. I think maybe our radiologist can answer this. Does dual energy CT give more benefit to CTPA in diagnosing pulmonary embolism?
Definitely. Dual energy CT is a low energy CT, which uses monoenergetic X-ray beams. So there are iodine maps and Z effective, which help in the lung perfusion assessment. And monoenergetic low energy reconstruction known as low mono E allows for the iodine boosting of pulmonary artery. So it is useful in suboptimal contrast opacification.
So thank you so much. I hope that has answered and satisfied Dr. Chatterjee. So the next question is from Dr. Soren Banerjee, West Bengal, from Burdwan. He's asked the same question again, so I must take it up. What are the features of pneumothorax in lateral view? So anyone would like to answer that? Dr. Nirupam, Dr. Girish, anyone can take this question. So basically, even in lateral view, we would have pneumothorax, the standard signs only. I don't think it should make much difference. It depends on the site. Is it loculated? Is it what is the amount of pneumothorax? Is it,
Mainly it will be against gravity.
Mainly it will be against gravity, right? I'm trying to quickly take up as many questions as I can. I'm sorry that it's in the interest of time, I can only take up so many. So Dr. Thota Vindhya from Karnataka, Bangalore is asking again for the areas on chest for ultrasound for obtaining good diagnosis. So I would recommend you look up the blue protocol and the blue points and the flaps. Flaps would be laterally, and the upper and the lower blue points, these are the standard points. But feel free to search the thoracic cavity. Do not be limited by these points for inspection. This is a question from Dr. Ajay Lanjewar. What is the best time to get training for chest ultrasound residency or practicing chest physician? How many hours can be minimally advocated for beginners? Dr. Ajay, it is a time-consuming skill set. I think working in an area, if you have an ultrasound available in your ICU, please read up and feel free to use it. You may not be accurate, but you can always cross-check with the intensive care team if they are good or if they are experienced with using the ultrasound, or you can always, contact the friendly radiologist. Okay, I would like to see what is Dr. Pratap from Guntur, Andhra Pradesh is asking the best and most accurate way to measure RVSP. So Dr. Pratap, this is also beyond the scope of today's webinar, but I recommend that I recommend you look up this video again, especially Dr. Girish's presentation. It would be very helpful. It will be uploaded within the next 12 hours or so on the CCI official YouTube channel. Once again, I would like to thank our dear audience for their support. We had 914 logins. This was a relatively complex topic, but I am very happy that the pulmonologists are now venturing into radiology in the ICU. They are actually this is a step in empowering pulmonologists, and I'm very happy with the turnout. And I would like to thank our wonderful, wonderful panelists. Thank you once again, and our dear panelists. And a take-home message quickly from Dr. Girish, Dr. Nirupam, and Dr. Nikhil. I would like to start with Dr. Nirupam.
Take-home message is that if you are a good pulmonologist, you must know at least lung radiology. And lung radiology is very important. As the previous question was that how much training is required for ultrasound. As PG days, I do remember that we have to, we suspect minimal pleural effusion or loculated pleural effusion, and we used to send it to the radiological department for marking. Say they used to mark that effusion, and when we used to tap, there was dry tap. So the main difficulty was that the position in which they used to do ultrasound was different in which we are trying the tap. So you should know your basic. The basic of ultrasound is very much important. because when a patient is bedside and randomly you are like on the bedside, you are doing ultrasound, and then at the same point in same position you are doing tapping, you are 100% successful. So the ultrasound is now, previously it was not taught, but now I think so many courses are there, and it is the demand of hour. Similarly with echo, like a patient, you are on call and a patient comes and you don't know how to do a screening echo, then you have to wait for the cardiologist to come and do it. The time is lost, and same way you can lose patient also. Dr. Girish was speaking about how meticulously he tackled the patient within 15 minutes. Unfortunately, the patient was not saved, but that skill counted. So a good pulmonologist must have good radiological skills also. Many a times CT says something, and when you look up at the CT, you find there is another thing which is not mentioned in the CT finding. So unless you know that CT reporting, how you will proceed. So both are very much without radiology, you cannot be a good pulmonologist in these days.
Thank you, Dr. Nirupam. Dr. Girish, take home message from you.
Well, though I don't have a gray hairs, but I still feel
you have gray matter. You have proven it.
But I still believe that as a clinician, you should have a proper mixture of your clinical knowledge of your basic pathophysiology and then correlate it with the technology. So without your basic pathophysiology, without your basic clinical acumen, you cannot take the benefit of technology. And while we are applying this on the patient, it has to be a mixture of both. And don't get driven by the technology is what I'll say. You have to have a proper mixture blender of both.
Thank you, Dr. Girish. Very, very aptly said. Take home message from Dr. Nikhil, please.
From my side, it is just that the collaboration between radiologists and pulmonologists or any other clinical branch is very essential, because generally we don't get the clinical history properly and the reports go haywire. So the collaboration is the must.
So I understand and I agree. I thought every radiologist complains about this, that the clinicians don't send a good history. And I think I took Dr. Nirupam's advice very, very seriously, that every pulmonologist should have a good radiologist. So I married one. Make my life easy. Thank you very much, dear panelists. Thank you, dear audience. And I think take-home message from my side would be that wisdom should prevail. All these radiology, from X-ray to CT to ultrasound, all of this is to aid our clinical judgment, but clinical wisdom must prevail. Thank you very much. And for all pulmonologists out there, if we can put an ultrasound inside the bronchoscope and do the ultrasonography from that point, we can definitely do it transthoracically from outside the lung cavity. Thank you very much. Thank you very much, and good night.
Good night.
Thank you. Good night. Thank you.
Good night. Thank you.